Think about this scenario. A kid takes a tumble, maybe on the playground, knocks a front tooth, looks okay, maybe,
Right.
but inside, something critical has stopped. The root just isn't finishing its growth.
Dentists see quite a bit. The living part inside, the pulp, it dies before the roots fully form.
And you get this open apex, leaves the tooth pretty exposed, doesn't it?
Totally vulnerable. And that's exactly where this procedure, apexification, comes in. It's designed for these immature, non-vital teeth.
And you're saying it's changed a lot.
Oh, dramatically. We've gone from these older methods that were, well, long and kind of uncertain to techniques now that are super predictable, sometimes even done in just one appointment. It's a huge shift for patients.
That sounds like a massive leap forward. How has this change happened, and what does it mean?
Okay.
We're digging into an article, Apexification, Modern Protocols for Open Apices in Endodontics, plus some newer studies. Basically, we want to give you the shortcut to understanding this whole area. Sounds good. So let's dive in. What exactly is this open apex, and why is it such a headache for the tooth?
Normally, after a tooth pops through the gum, the root takes about, say, 3 years to fully form and close off at the tip.
3 years.
But if that young tooth gets hit hard or gets deep decay...
Like the playground accident.
Exactly. The pulp can die off. That's pulp necrosis. And when that happens, boom, root development just halts. Leaves the end of the root, the apex, wide open, unfinished.
So not that nice tapered close point you see on a fully grown tooth.
Pretty much, yeah. And that's a real clinical nightmare.
How common is this?
Often those front teeth, the maxillary incisors, you know, the ones right in the smile line.
And you said it's a nightmare.
Well, 3 main things. 1, cleaning out that wide open canal, really tough to disinfect properly. 2, there's no natural backstop, no apical stop inside. Makes it super hard to fill the canal without pushing material at the end.
Okay.
Those thin, unfinished canal walls, they're incredibly fragile, very easy to fracture the tooth later on.
Yikes.
Exactly. It's designed to tackle those specific issues. The traditional way was using calcium hydroxide. You'd pack it in there for months, hoping it would trigger the body to form some kind of hard tissue barrier at the end.
A waiting game, then.
And honestly, not always predictable, but then came the big shift. MTA, mineral trioxide aggregate.
MTA. That's the game changer you mentioned.
Absolutely. It turned apexification from that long, uncertain process into something much more precise, often a single visit. It was less about hoping for a barrier and more about creating one directly.
So the goal is still the same, get a hard barrier at the root tip.
That's the core aim, yes. Induce a rigid apical barrier. Close off that opening. Now, there is regenerative endodontics, which tries to actually regrow the root tissue, but its success is, let's say, more variable. Apexification is often more predictable for just creating that seal.
And what causes this open apex in the first place? Trauma?
Yeah.
Anything else?
Those are the big ones, yeah. Pulp necrosis from trauma or caries. But also, sometimes braces orthodontic treatment can cause root resorption. Periapical infections can do it. Even things like over-instrumentation during a root canal or developmental quirks like dens in dente or dentin dysplasia.
Okay, so that shift to MTA and similar materials, these bioactive materials, what are they and what makes them so much better?
Right. These are the stars of the show now. Materials like MTA, biodentine, ortho-MTA, endosem, bioaggregate.
They do differently.
They're pretty clever, actually. They form a physical plug at the apex, a 3D seal. But it's not just a passive plug. The material itself mimics hydroxyapatite.
So it's biologically compatible.
Highly. And here's the really cool part. They release calcium and phosphate ions. This actively stimulates the cells around the root tip, the osteoblasts that make bone, and cementoblasts that make cementum, the stuff covering the root.
Wow, so it's encouraging the body to finish the job.
Exactly. It's not just blocking the hole, it's actively promoting the formation of a natural hard tissue barrier.
Which helps with?
Killing bacteria. That alkaline environment is antimicrobial, which is a huge bonus for disinfection inside that canal. It's a completely different philosophy working with the body's healing potential.
That's fascinating. But it's not just the materials, right? You mentioned things have become more predictable. What else changed? Tools? Techniques?
Absolutely. The materials are huge, but how we use them and see what we're doing has also evolved massively. Magnification is key.
Like using microscopes.
The dental operating microscope, the DOM, it changes everything. You can see incredible detail down at the root apex. Things you'd completely miss with the naked eye or even basic loupes.
So you can place that plug much more accurately.
You can ensure it's well adapted, properly sealing the end. This directly bumps up the success rate and improves the long-term outlook for the tooth. Fewer errors, better seal.
Okay, so the microscope gives you the visual precision. What about seeing before you start? Diagnostics.
Great point. Advanced diagnostics are critical too. Traditional 2D x-rays, like the little ones you bite on.
Limited view.
Now, CBCT, cone beam computed tomography, that's the gold standard.
That's the 3D scan.
Exactly. It gives you a three-dimensional view of the tooth and bone. You can accurately measure how thick the remaining root walls are. Remember, they're fragile. You can see the exact shape and size of the open apex.
So much more information.
Tons more. And it's invaluable for monitoring healing over time, too. You can actually see the bone filling in, see if that barrier is forming properly.
Are there other tests involved besides imaging?
Oh yeah, definitely. A full workup includes testing the tooth's vitality or lack thereof. We use things like cold tests, heat tests, electric pulp testing, sometimes even more sophisticated things like Doppler flowmetry to check blood flow, or pulse oximetry, patient history, what symptoms they have, checking for any tooth discoloration, swelling, probing around the gums. It's a whole picture.
Okay, so putting it all together, the materials, the microscope, the CBCT,
Right.
what does the actual treatment look like now? How does a dentist decide how to approach a specific case?
Well, first you got to classify that apex. Is it what we call a blunderbuss apex? That means the walls are really diverging like a wide funnel. Or is it non-blunderbuss, where the walls are more parallel or maybe even slightly converging towards the tip?
Does the size matter too?
Critically, we measure that opening. Generally, if the apex is wider than about 1 millimeter, maybe 1.1 millimeters, apexification with these bioactive materials is often the most predictable route.
Right, and how does that classification, blunderbuss or not, size, dictate the treatment plan?
It guides the specifics. So say you have a non-blunderbuss apex and it's relatively small, like under zero point 0.8 millimeters.
Okay.
You might be able to use a bioceramic sealer with gutta percha if you can get what's called tuckback. That means the gutta percha sort of catches or tucks into the canal shape near the end, giving it some retention.
Makes sense.
If it's a non-blunderbuss apex wider than 0.8 millimeters or any blunderbuss apex, regardless of size, the go-to approach is different. You place a solid plug of bioactive cement, usually MTA or biodentine, at the apex, typically aiming for about a 5 millimeter thick plug.
A 5 millimeter barrier.
It provides a really solid seal. Then, once that plug is set, you fill the rest of the canal above it, often with gutta percha and a sealer. For those blunderbuss cases, combining gutta percha with a bioceramic sealer for the rest of the fill is often preferred.
Okay, let's walk through the actual procedure. You mentioned it could be 1 or 2 visits. What happens in a typical 2-visit approach?
Absolutely critical. Success hinges on doing this meticulously. Let's start with disinfection. That's paramount.
Cleaning everything out.
Exactly. Now, for mature teeth, we often use stronger concentrations of irrigants like 5.25% sodium hypochlorite, the bleach solution, and EDTA to remove smear layer. But for these immature teeth with open apices,
You have to be more careful.
precisely, we typically use a lower concentration, maybe around 1.5% sodium hypochlorite, and we use special techniques to irrigate safely and effectively.
Like what?
Things like negative pressure irrigation systems, the Endovac is one brand, or using tiny microcannulas to deliver the irrigant right where it's needed without excess pressure. It's all about thorough cleaning while minimizing extrusion risk.
Got it. So, visit 1.
First, you get access into the tooth, always under a rubber dam to keep things isolated and clean. Determine the working length carefully. Then comes that irrigation sequence. The 1.5% sodium hypochlorite followed by saline rinses, maybe a final rinse with something like 2% chlorhexidine or 1% alexidine for sustained antimicrobial effect, and incorporating that internal heating or ultrasonic activation we talked about.
You put something inside the canal.
Traditionally, it was calcium hydroxide, still used quite a bit. Another option is triple antibiotic paste, or TAP.
Triple antibiotic paste.
It is potent stuff, but it has a known side effect. It can stain the tooth.
Oh, not ideal.
Exactly. So now there are newer options like modified versions of TAP designed to reduce staining, or things like Emdogain, which is a biologic material that might also help with healing and potentially has better compatibility with stem cells in the area.
Okay, so the tooth is cleaned, medicated, then the patient comes back.
Typically after about a week, that's visit 2.
Wait, to see if the medication worked.
Partly that, yeah. You reevaluate. How are the patient's symptoms? Any tenderness? Look at the x-rays or CBCT. If everything looks good, you proceed.
What happens in visit 2?
You repeat the irrigation, again with the 1.5% sodium hypochlorite, followed by 17% EDTA now to make sure the walls are clean for bonding. Then you carefully place that 5 mm bioactive cement plug right at the apex.
Using the microscope for precision.
Absolutely. You need to see exactly where it's going and ensure it's packed well without voids. Once the plug material is placed, you fill the rest of the canal obture, usually with gutta percha and sealer, then place a good composite filling to seal the top opening.
And what about protecting the tooth long term?
Good point. If the tooth has any existing cracks or even just fine crazed lines, putting a full crown on it after the apexification is finished is highly recommended.
Makes sense.
Yes, definitely. With materials like MTA and biodentine, because they set reasonably quickly and have such good sealing properties and biocompatibility, doing the whole procedure cleaning, placing the plug, and filling in one appointment is often feasible. Showing comparable success rates, especially in cases without large active infections, saves the patient time, fewer appointments.
What really stands out to you about the results people get with modern apexification? And where's this field heading?
What's really striking is the predictability and the speed of healing. It's become a solid, dependable, non-surgical option, even when you've got those really wide open apices or infections around the root.
And how do you track success long term?
There's a pretty standard follow-up schedule, usually checkups at 1 month, 3 months, 6 months, then a year. That 1 year mark is often when a follow-up CBCT is really useful to objectively measure the dentin thickness, see how the bone has healed in 3D, then maybe again at 2 years and 5 years. Consistent monitoring ensures everything stays stable.
So the future looks pretty bright for saving these teeth.
Incredibly bright. And the innovation isn't stopping. We're seeing even newer bioceramic materials coming out. Things like Total Fill BCRM or BioRoot RCS, they claim even better handling, better adaptation to the canal walls, maybe less potential for discoloration than some earlier MTAs.
Wow.
Yeah, some really futuristic stuff being researched. People are experimenting with 3D printed apical barriers. Imagine creating a custom fit plug based on the patient's CBCT scan, perfectly tailored to their specific root shape.
Whoa.
Exactly. Still experimental, but very cool. And then there's the whole area of regenerative apexification, trying to actually regrow the pulp dentin complex using stem cell scaffolds, maybe combined with PRF membranes, that's platelet-rich fibrin, made from the patient's own blood to concentrate growth factors.
So moving beyond just sealing towards actual regeneration.
That's the ultimate goal for some researchers. Future work is really pushing the boundaries, treating bigger lesions without surgery, refining these microscope techniques, developing even smarter biomaterials.
It's really been quite a journey from this really challenging problem of a damaged young tooth with an open root
Yeah, a clinical puzzle.
to these incredibly sophisticated, predictable solutions we have today. The materials, the tools like the microscope, and just refining the step-by-step process have changed things.
It really is a testament to innovation in dentistry. Think about how this deep understanding right down to the cellular level with these bioactive materials, combined with high-tech imaging like CBCT, lets dentists do more than just fix things.
What do you mean?
Well, we're actively guiding the body's own healing. We're creating conditions, using materials that talk the body's language to encourage natural repair and even growth in ways we couldn't really do reliably before. It makes you wonder, what other parts of medicine could benefit from that same kind of approach? Precision biological engineering, mimicking and boosting the body's inherent ability to heal itself.
That's a really powerful thought to end on. Okay, that wraps up this deep dive.